Hi, I'm Maureen Kiley, and I'm the founder of the South Shore Local Community Directory and the CEO of Breakaway Growth Operators and Chief Strategist for YapPay. Now, this isn't about me, but I thought I better introduce myself. And I am interviewing local businesses for our community hub. And Ruthie is a nurse practitioner and a lot of other things that I'm introducing here. And she is owns the company TrustPoint. I'm gonna get this wrong. So TrustPoint Primary Care.
Yep.
Okay. Okay. So Ruthie Estabrook is here with me. This is about her and her business and how she got into working in primary care and some other things. And we're going to start off. Ruthie, thank you for taking the time to out of your busy schedule to meet with me and participate in South Shore's local directory group. And what I'd like to do is start off is kind of talk to everybody that's watching this video about your business, or actually about you, who you are, where did you come from, are you a Floridian? And I'll let you talk about that, and then we'll kind of talk more about what you're offering the community with TrustPoint.
Okay.
It's all yours.
Oh, I thought you were going to ask me a question. Make it easy. Let's see. So, am I a Floridian? It's probably a 50-50 at this point. I moved here in 2005 with my family, and I've left a few times and come back a few times, but I'm originally from Boston.
Oh,
Well, the greater Boston area. I grew up north of Boston. So, I've been a nurse for a very long time. I'm older than I look. Let's see, I've been a nurse since 1984, 85. I trained in the military. I got my LPN, transitioned to my RN in the 90s, and kind of was just staying there. I got my master's degree. I got my MBA first, and then I had four children that I raised alone. And in order to answer the question, well, why do I have to do my homework? So I went to school. So if mom was doing schoolwork, the kids did schoolwork. And that
oh,
kind of blossomed into my master's in business administration and then into a PhD in healthcare administration with the idea that I could teach. And there are a lot of people with their PhD in healthcare administration, and I was still working as a nurse, so I decided to go back and get my master's in nursing. And that took a long period of time. There were a lot of, ups and downs. And then I stopped in 2015, just because it just, you know, at some point you think, okay, I have enough education. This is enough. And nurse practitioners at that time were still under restricted practice in Florida. And what I could see from my colleagues that went ahead and got their nurse practitioner license, they were basically just the handmaiden that worked all the shifts that no one else wanted to work or the provider didn't want to work. And they weren't really getting paid a whole lot more than what I was. So I decided to, put that on a back burner and transition to about 2022. I kind of looked at my retirement and I looked at the economy and I went, I don't want to shake hands at Walmart, to supplement my income in retirement. I think, do I even really want to retire? And the answer was no. And, in a 30 some odd year career in nursing, most of it I worked in ICU and then the other half in the emergency department. And in the emergency department, a pattern kind of emerged, which I'm sure you could Google anywhere and find that a lot of people use the emergency department, especially at night, as their primary care because they can't get into visits, or they just don't know how to access the healthcare system, appropriately. Like, they'll have stomach pain, and instead of calling their doctor, even if they have a relationship with them, they think, oh my God, it's an emergency, I gotta go to the emergency room, and then we give them lidocaine, Maalox, and we send them home. The problem is it sends them a bill for about $2,500, so that's some very expensive lidocaine and Maalox, which they
yeah.
could have managed on their own had they had proper education. And when we started asking some of our patients, well, why did you decide to come to the emergency department? They were like, well, I had really bad stomach pain for a week. And we're like, well, what did you do? What did you do to, you know, talk to your doctor about it. And they said, well, my doctor just breezes in and breezes out in 15 minutes. And we started hearing this as a pattern. People that had lesser insurance or no insurance, they came to the emergency department because primary care would ask them for a giant copay, or if they were uninsured, they would want to pay for the whole visit up front, which, they didn't, they don't have money for health insurance. They definitely don't have money, $250 to, manage that kind of a payment. So while I was in NP school, it kind of, what was originally supposed to be just telehealth to supplement my income kind of blossomed into TrustPoint Primary Care. I came up with the name. I kind of did a national search to find, a number or a name or a group of names that would generate trust, and that was nowhere else to be found in the country. There is a hospital in the Midwest called TrustPoint, but it's 2 words. So I mushed the words together, and I thought, one of the things that will be helpful is I want to serve the underserved community, and do the things that other practitioners with large overheads cannot do. And one of the things that I'm very, very passionate about is, one, taking care of, people that have Medicaid. I don't think that that's a point in life that anybody ever chooses or wants to, have Medicaid insurance as opposed to Medicare. And they do find it very, very difficult. The system is not designed to supplement or, support them. It's just kind of, they're like the last bucket that everyone falls into if they qualify for insurance. And they have a lot of chronic medical conditions that, you can't address in 15 minutes in a doctor's visit. And the doctors are overwhelmed because they have these giant panels of patients. So it's really no fault of the larger practices, but they just can't take the time to do the education with the patients. And then the patients go home with a list of prescribed medicine. They probably have 2% of the knowledge, of what they need on how to manage the medicines or why they're even on them. They don't understand half of the stuff that the doctor talks about, and then, it's on to the next visit, So the problem is then you don't have compliance with the medications. The patients get sicker, and then they do wind up in the emergency department with long-term chronic illness. And we see that a lot in the emergency department at night. We have people that have, sky-high blood pressure, and they come in a critical state, and we're like, well, you have this medicine prescribed. We can see the prescription. Why don't you take it? And they went, well, I had to kind of decide, do I eat or do I buy my medicine? And I think it's a breakdown in the system, because they don't realize that if they don't take their blood pressure medicine, they end up with chronic kidney disease, or they can't be bothered, or they don't understand. So I have very frank conversations with a lot of my patients, and I said, if you can't take the time or you can't be bothered now, life is going to change for you, because with chronic hypertension, you will end up on dialysis eventually. It will kill your kidneys. And then you will have 3 days a week for 4 hours a day until you can get a new kidney, or if you're lucky enough to have your kidneys recover, to sit in a dialysis chair and just ponder your decisions, And I know it sounds a little rough, but sometimes it's actually the wake-up call that a lot of people, they think, like, everybody understands what dialysis is. It's a terrible long-term condition, and it's very expensive. And really, no one would want to go there if they had the opportunity to intercede in the beginning. So, that, like diabetes, you could just name a chronic condition, and I could give you the backstory of why people have no compliance, or they don't understand why their body isn't making insulin, or if they have type 2 diabetes, why it's important to do what they need to do. So I take that time with my patients, even patients that have, mild psychiatric illness. In general, psych nurse practitioners or a psychiatrist would have to take that over. But a lot of the patients don't understand why they're taking the medicine that they are. The doctor, they went for depression, they're taking this, what they call an SSRI, and they don't understand how it's working for their body. And there's no therapy that goes beyond it. They're just taking the pill, and they're saying, well, I'm not getting any better. And they don't understand that with a psychiatric illness, you have to do a little bit of footwork. There's homework that goes home with that to help them, deal with, there's certain conditions that I don't treat like schizophrenia, things that are more of an organic, that's definitely something that's out of my scope. But with depression, people have, people don't just wake up depressed. Things have happened to them. They have PTSD or, situational crisis that happen, and they happen recurrently over their life. And then in time, it's kind of like Pavlov's dog. Your brain kind of learns to react a certain way to a certain group of stressors, and you have to teach yourself to unlearn those behaviors. And you can't do it with just medicine. Medicine will give you the support so that you don't feel terrible, but you really need to unlearn the behaviors, because we all know that the lion isn't chasing us, and that you live in the United States. There are not bombs crashing around you, so every loud noise is not an IED exploding behind you. So what I tell some of my PTSD patients, I said, think of them as lies that you've told yourself, and that when you start to feel those triggers, you need to identify them, and I have a lot of them writing long journals, and I spend sometimes 2 or 3 hours with some of my patients, and we go over a lot of the different therapies, we practice them, and I do that with all of my patients. If I book 30 minutes and, or if I book an initial appointment for an hour to talk to someone, some people get it right away, and then we can just do follow-up and it's much faster. But if I can sense that a patient really isn't kind of grasping what's going on, I go back and I do more education. And I think a lot of practitioners kind of dumb down the education, and what I found is I can actually go into quite explicit detail about human physiology, why things work certain ways, and the patients really do get it. Sometimes you have to give them a little bit of time to kind of grasp the full circle of why they're taking a medicine, why it works, and whatnot. Just like I was telling you earlier, in weight loss, some people will take the GLP, the injectable weight loss medicines, and I saw this a lot when I was in clinical, that they're either, one, not successful, or they have terrible side effects. And the GLP medicine it's a strong medicine, and it will work no matter who takes it, if they understand why they're taking it, and if they understand the diet. And then but there's another piece to the clinical package, which you can find research out there on the internet, and actually on LinkedIn I've actually posted a few articles that kind of discuss the medication, and you have to understand what goes on in your gut so that you can understand why a GLP actually functions and how it works. And there actually might be a few on my website too. I've done some of those as well. But and I try to post pretty much everything I post in LinkedIn.
Yeah, I'm sharing some of the screen.
I post as articles or little tidbits of knowledge that go through. What I did for my patients that I treat in weight loss, if you scroll up, you see the full script. I actually, one of the things that's very, very important when you take a GLP product is to understand your gut biome, because when you take the GLP, it slows down your gastric motility. Some people call it like a chemical gastric bypass. It's kind of true in a sense. But the problem is if you don't have a really strong gut biome when you start a GLP, one, you're going to eat less food, and when you eat less food, you take in less nutrients. But basically, if they don't understand the mechanisms of action in your gut, that's how they end up with blockages. Because if you don't drink enough water, and I've heard some, practitioners like, oh, now if you take this, I'm going to give you Zofran, and you need to drink a lot of water. And that's not proper diet education. And the people will lose weight, but sometimes they get this hollow look, in their face, and because they've lost weight so fast, but their protein intake is terrible, or they don't have the nutrients in their gut. And if you're taking in less nutrients, it's very important that the nutrients you do take in, your body can absorb.
So can I ask a question? Do you actually go through nutrition with people too? Are you part nutritional too?
I do nutrition in probably 80% of my visits. Nutrition is what some people may or may not realize is your body is constantly regenerating its cells, like head to toe, brain, spine, everything. You're always making new cells and regenerating, new tissue. And so you can do diet education with cardiology, with urology, with weight loss, diabetes, mobility, aging. It's important for every single piece. And what I found, like on my website, you see the little piece that says full scripts. That's actually an adjunct pharmacy that I provide to all my patients at my cost. I could put it out at commercial rate, but I want it to be accessible to people, and anybody can click on that and join. You don't have to be one of my patients. And one of the things that I highlight throughout my practice that I did a lot of research is when you take a probiotic, it's very, very important to maintain your gut biome. And I go through education on what the gut biome is. And a lot of people think a probiotic just makes them regular. It'll help their, bowel regimen. And while some people will see an improvement in their regimen, that's really not what your gut biome is about. There's multiple million different bacteria that live in your gut. And if you had a sterile colon, you would not be able to survive. The only time your gut is sterile is when you're in utero, before you're born. And if you saw sterile stool, if you've ever breastfed your child, if you had a baby, it's yellow and it's very runny. But that's what a sterile colon, fecal matter looks like. And as you develop the biome, that's what your body needs to survive. So without it, if you had a sterile colon, you would not be able to absorb nutrients. You would be able to absorb salt and water, and that's what your large intestine, basically, that's its only function, is to excrete waste and absorb salt and water. But your small intestine is where your gut biome lives. If you take the wrong, there's a million probiotics out there on the market. If you can sell it, people will buy it. Or if people will buy it, you can sell it. Gummies, they're basically just gelatin. That's all you're getting. There's probably no... I've never physically tested them, but I would think that the processing would kill the bacteria very quickly. Or if they're in a bottle, or, if they're not made a certain way. And when I did my research, I found that there's probably about maybe 10 or 12 really good probiotic products. And probiotics are different based on what you want them to achieve. So when they say they're for women, women's health probiotics, like I had a woman, she's like, oh, I didn't notice any difference at all. I've been on this, and she showed me the package, and it's basically, so women actually have two biomes. You have a vaginal biome and you have a gut biome. And the ones that are quote unquote for women's health in general will deal with your vaginal biome, not your gut biome. They'll help a little in your gut area, but in general, what they'll help with is prevention of UTIs. There's a whole flora that works with that. So it's important to know, like, the different bacteria that live, they all produce different chemicals in your system based on what you eat. So that being said, it's important that you take what is now being, like the new great thing, but it's a prebiotic. And what happens is, when you eat fiber, not roughage, fiber, your body can't do anything with it. But the bacteria that live in your gut can. They metabolize the fiber, and the byproduct of their digestion, and each one produces a different chemical. That's the product that your body needs. It can regulate, the brain fog, I won't get into specific chemicals for you, but the one that most people are very familiar with hearing is cortisol. It will help regulate your cortisol levels, which if you have diabetes or type 2 diabetes, your cortisol levels are probably up and down, and they know about that. The gut biome will actually help maintain a stable cortisol level. So it can help with inflammation, swelling, inflammation, cortisol levels, histamine levels in your stomach, tissue healing. All of those things derive from your gut biome. So when you hear that, there's a new development and, in your gut biome, kind of people are over it at this point because the commercial industry has kind of saturated the market, and they've done a great disservice. And I'd almost say that the pharmaceutical companies really don't want you to find out that your body can actually correct probably 80% of what you have. It doesn't happen overnight. People didn't get hypertension overnight. They can't correct it overnight. You can with medication, but over time you can actually heal a lot of your vasculature with your own natural diet and probiotics. I would never tell anybody stop taking your blood pressure medicine. I put people on blood pressure medicine all the time. It does have a purpose, but it's important.
But you can adjust it.
You can,
right?
Over time, you can adjust it. That's why people that are on the GLPs are now noticing that the more weight they lose, if they actually get a good practitioner that does a lot of diet, they lose the weight. So some of their blood pressure will come down based on weight alone. But the GLP is actually a large portion of your gut biome. There's actually bacteria that live in your gut that when you feed them appropriately, your body actually will make its own GLP and help regulate.
Can I ask a question? So if someone's watching this video and they want to know about this, do you have like a program where people come in and do certain tests for this microbiome?
No, I mean, you can go out. There are people that will charge you a lot of money and test your stool and to find out what's in there. It's not really necessary because you can do one of the products that I found. It's manufactured by a company called Seed, and they do a 14-day gut reset. It's not a purge, so it's not something that's going to flush out your colon. It basically gives you 14 days of a mega dose of pre and probiotic, and in the 14 days, it will kind of get you to about 75% of where you should be. But anybody that would meet with me, and if any of my patients ever watch this, they will tell you, yep, I go on and I do a lot of education. And I don't have a specific program because everybody's different. Your needs are different than my needs, that are different than somebody that's 80 years old or somebody that's 20. So there's a lot, I do a lot of it with HRT patients. Hormone therapy cannot be reversed with probiotics, but some of the symptomology of menopause fog, the fogginess and the hot flashes that come can be alleviated is probably the better term for that, or made less. Really the only product, as you age, you are going to make less hormones, so you will have hot flashes. That's just a fact of life. But there are ways to supplement it so that you don't have to take a lot of different hormones, so that you can manage the symptoms and, do that. And that is a big piece of my practice. I do a lot of hormone therapy with women and men too. Men actually go through a menopause as well, or a menopause. And I find out that a lot of them, they have, we can test your body for hormone deficiency. But as far as like a gut reset, it's easy to just assume that if you're in your 50s, your gut biome is probably pretty poor in general because of medication and stress and whatnot. And you can't do any harm by just doing the gut reset. And you can do it with other, if people didn't want to buy that specific product, I can give them a list of the generic products. CVS and Walgreens actually have a few generics that are excellent.
So do you take, I just want to ask for people that might be watching this, so you're a primary care clinic. Mm-hmm. You do a lot of different things. You have an extensive education. And so do you do insurance? Are you private pay? How does...
I do both. So
okay.
One of the things that I realized early on was we actually have a second corporation. It's called TrustPoint Charitable Care, which haven't done a lot of work with it, but the idea behind the charitable corporation is it's a Florida nonprofit, and it basically absorbs the portion of a visit that a patient can't pay for. I would love it if somebody listening to this would, grant some money to the checking account so that it could actually produce some income. But I do both. I do insurance, I do cash pay. I have, I guess I can accept, there's some credit people that do like, you go at the pet store, they're like
Yeah, there's like a care credit or
yeah,
something
Care
like that.
Credit.
Yeah.
There's a few others that I've partnered up with, and my payer system through my electronic health record kind of accepts all of them. So, and I do, payment programs for people that just can't afford, they just can't afford the care, but they need it. And my prices are really, really pretty low comparatively to most people, because it's more important to me if someone can't pay me. That's not really why I'm doing this. I would rather them get the care, and worry about getting paid a little bit later. And I think in time, people, I've never had a problem with that. I do have some people that owe me a little bit of money, but they're healthier now. And to me, that was the payment. It was, when I see them, chronically ill, and then now they're compliant with their medicine, to me, that's the payment. That's what it's more about. And I have that liberty to do because I don't have to answer to, a larger corporation, and one of my big goals was so that, access, like I discussed earlier, when I started to take insurance, I'm out of network for pretty much everyone. I'm slowly getting contracts to become in network. I do take Medicaid and Medicare for sure. But what I heard from a lot of the Medicaid patients that come to the emergency room at night, with their kids, and they really just have like the flu or they have strep or, but the problem is and maybe society understands this, but if a patient works or doesn't work, but say for our argument, say they work and they qualify for Medicaid, so they're minimum wage. They can't afford to take a day off from work. One, they probably work in a job that they're lucky that they, have insurance if they have any. And if they don't, they have Medicaid. But if they take a day off from work, that's a whole day's pay. They don't have sick time. And if their kid is sick, then they have to take a day off from work. Their kid has to take a day off from school. And then they have to find a provider that can accommodate whatever time they can afford to take off.
So that's why they end up in the emergency.
That's why they end up in the emergency department. So they can't, when they say they can't get an appointment, they can't get an appointment because primary care closes at 5 o'clock or it's not open on the weekends or holidays. And I am. I've worked nights primarily my whole entire career. There's short periods where I've worked days, and I'm available to my patients 24/7. And people kind of scoffed at me in the beginning, but I see a lot of patients in the middle of the night. They text me and they say, "Hey, I'm feeling really terrible. Do you have a minute?" And I can pop them on the camera. I can kind of assess from the camera, and you'd be surprised what you can see on telehealth when you assess a patient. And if they're in the local Hillsborough area and if I'm on the camera and I don't like what I see, I will go to their house, and I will do a physical one-on-one with them, so that they don't have to go in the emergency department. And some of my patients, especially the Medicaid ones, are bedridden, so for them to get to their primary care doctor, no one does house calls anymore, but the concierge medicine will, but you pay $20,000 for concierge medicine, and they don't have that money. To me, I just go to their house and I can see them. And Medicare and Medicaid, actually, if you book a home visit, they actually do pay you a little bit more for the visit. But what you get out of it as a practitioner is priceless,
Yeah.
And you can see a lot more about your patient too. Everybody can say, well, I live in this house or I live here, but you can gather a lot about your patient just from their surroundings, good and bad. I think it's important that you not be judgmental if you're a practitioner and thinking about doing home visits, because not everyone lives like, you and I do. But it's important information to understand. It gives you a wealth of information about, can they do this? Is this, is the treatment plan that you're giving them something that they can follow?
Right.
When you see them for 15 minutes, you can't make that assessment, and you can't make it reasonably. So.
Well, Ruthie, you have an incredible business.
So
I mean, in your whole premise of how you develop this based on your education, everything you do. So I think everybody that watches this video needs to go check out your website and find out what you do, because this is incredible. And one of the reasons why I started this project to highlight on local people is because of when we moved here, we didn't know anyone.
mhm.
And we're still frustrated with healthcare, and we're still frustrated with dental. I mean, I was just talking to another business owner yesterday, and he said he's been here 6 years, we've been here 5, and we're like still talking about how we can't find the right mechanic and right dentist. So it's
Right,
like,
right,
and then we're driving to Tampa dealing with traffic that'll bump your hypertension.
right.
And for our doctor, and our doctor now just got rid of my insurance. So it's like, people need to hear, and you would never hear this from most physicians, what you're saying here. This is really incredible information,
So
and what you're doing in the community is really fantastic.
well, and one of the things that I mean, and I guess I'm lucky that I have the MBA background too as well. When I apply to the panels, to take insurance, a lot of them say, "Oh no, we're closed. We have enough practitioners." And what I realized early on is, while they won't admit it, the panels are closed to nurse practitioners. And especially, and I kind of understand it from a business perspective. If I'm one provider in a practice, we actually have two. I have one other colleague who is a nurse practitioner who works for someone else. And when we start to get more contracts and need more patients, he works up in the new Tampa area to handle that area. He's going to start seeing patients up in that part of Florida or Tampa. But what I realized is that there's probably a lot of nurse practitioners that they take cash now, or they do cash pay only because they can't be bothered with being constantly told no from the insurance payers. They would gladly take insurance, but they can't get a panel, or they can't get and a lot of them, once they get a panel, they won't talk about it because it's almost like a conspiracy, that they said, "Oh no, I got a panel, I have this pair, I'm not going to say anything," because they're afraid that the panel will get pulled. And a lot of them have had their panels pulled for no reason, so they'll start their practice and they have real estate and rental and bills, and they'll have what they call a capitated contract. So they'll get, the insurance company will hand them 20, 30, 200 to 300 patients to manage, and then they'll get a notification the next quarter that their panel is being pulled because they wrote too many prescriptions for that panel or those patients. And it does a disservice to the patients too, because they start to build a relationship with the provider and start to, go somewhere. Like your doctor, he no longer takes your insurance. It was no fault of his own. I'm sure he didn't decide, I used to think that they decide oh, I don't want to take that insurance anymore. And I could never understand why. Why would you do that? And really, it's not the provider, it's the insurance company. And being out of network.
Well, and the margins are getting squeezed too, Ruthie.
Sure.
I mean,
sure.
those insurance companies do not pay most physicians or nurse practitioners what they're worth. I mean, if you got someone that's really good, like someone like you, and my perspective is, man, hang on to them, because the medical industry is just put a pharmaceutical on it. That's
Right.
how I look at it.
Right.
And I'm not that way. So I can't wait to come and see you. I'm very interested in the gut biome. So this seed thing. So I'm going to talk to you about it off of this interview.
Sure. I'd be glad to.
But I really appreciate you taking your time.
Yeah, I could talk for hours.
Explain this.
The time we have isn't reasonable. I could go on for a long time.
When we launch the podcast version of this, I'll have you on for sure. And because these interviews with our businesses that we're putting into this local community hub is been amazing. The interviews have just been amazing, and most people would not know this had we not done this today. So I really appreciate you taking the time out. It was really valuable information, and I look forward to seeing your business blossom and people getting the right kind of care, because most of the time out there, they're just putting a Band-Aid on it.
I'll be better dressed next time.
It's okay. All right. If you guys want that are watching this, we're gonna put at the end of the video your page. So but what's the best way? Just to go to your website, book a consultation?
If you really wanted to, so you can book things through my website. I will tell you, I made my website myself, so it's as good as my skill level is, but they can just call the number, and then you can call or text it. It actually comes to my phone, either way, and they can just text me and I'll get back in touch with them right away. I usually have about maybe 4 hour lead time, to develop a chart and book a visit with someone once they've texted me.
Nice.
So.
Okay. All right. I'm going to stop the recording, but I appreciate you doing this. And everyone, you need to go to her website and look at the link in the description below.